Okay, for those of you that are entering the room, I want to thank you for joining us for FNLA Nights. And we'll wait till we have a little more of quorum here. Hope everybody is doing well. Like your hat there. I'm sure Peter Jones has the elf on the shelf somewhere.
I have one that wears a lab coat, though.
You've already outdone us. Okay, so I think what I'll do is I'll start to introduce Dr. Ballantyne, who really needs no introduction. Again, I want to welcome everyone for joining us for FNLA Nights. We're planning some future meetings, so we'll let you know. Christie is an internationally renowned expert on lipids and atherosclerosis, as well as cardiac prevention. His research interest is in the prevention of heart disease, which has led him to become an established investigator for the American Heart Association and received continuous funding from the NIH since 1988 in basic research in leukocyte endothelial interactions, translational research, and biomarkers in clinical trials. His many accomplishments have included being elected as fellow of the American Association of the Advancement of Science, American Society of Clinical Investigation, and the Association of American Physicians. In 2012, he received the American College of Cardiology Distinguished Science Award. In 2014, 2015, Thomas Reuters recognized Christie as one of the world's most influential scientific minds. Dr. Ballantyne is cited as a highly cited researcher. He has over 800 publications in the area of atherosclerosis, lipids, and inflammation. Christie also serves on the editorial board for Circulation and JACC. Christie is the Chief of Cardiology and the Chief of Cardiovascular Research at the Baylor College of Medicine. He's currently Director of Cardiometabolic Disease Prevention at Baylor College of Medicine. I consider him a colleague and a good friend, and it's truly an honor to have Christie participate in our FNLA Nights. And with that, looking forward to hearing his presentation tonight on precision medicine. So Christie, thank you again.
Thank you, Guy, and thank you for that nice introduction. So precision medicine for cardiovascular disease prevention. From where did we come? Where are we now? And where are we going? So these are my grant research reports, consultation disclosure information. So where do we start? Start with the beginning, I guess. And we'll talk about risk assessment, genetic testing in the clinic, just touch on a little bit about therapies at the end for it. So, you know, if we take a look at genetics, you know, it doesn't begin with us, it begins with our ancestors. So this is a picture of my father on the right-hand side. My grandfather is on the left. I never knew my grandfather because he died of a stroke before I was born. And in the middle is my aunt, Merle. And when I was a junior in high school, my father had a myocardial infarction, had a cardiac arrest, was very fortunate to be resuscitated. The person who died at the youngest age here was actually my aunt. And the day of her first symptoms was the last day that she was alive. She lived on a ranch in Arizona. So it's one of the issues of why prevention is so important, because oftentimes the first symptom is also the last day that person's alive. This is my mother's side of the family. And she had 3 brothers. So question here, what genes did I inherit from my mother's side of the family? Well, one of them for sure is baldness. They were all bald by the time they were 40. And I was pretty much that way also. Here is the pedigree for it. So as I mentioned, that my father, my paternal grandfather died of a stroke. My maternal grandmother also died of a stroke. I never met her. She died when my mother was still a child. There's lots of diabetes. All of her brothers got diabetes. One had a stroke at a late middle age. As you can see on my father's side, lots of heart disease and diabetes. And then my oldest brother also died of a myocardial infarction. And once again, his first symptoms were also the last day of his life. So lots of diabetes and heart disease that runs in my family, which I'm sure shaped one reason why I got into cardiology. So I went to medical school at Baylor College of Medicine. I went to UT Southwestern for my residency. And where were we when I was an intern? Somebody came with an acute MI. We were basically palliating the symptoms. We'd give morphine, nitroglycerin. We'd watch them carefully. If they had VFib, we'd shock them. We would treat the complications. We'd treat heart failure, hypotension, arrhythmias, but we didn't really treat what was causing the infarction until later on when we did thrombolysis and PCI and stenting. And if you look at the aspects of prevention, it was even worse. Well, I don't know how you can be worse than just watching, but that's what we did for prevention also. High cholesterol was over 300. Systolic blood pressure, it was your age plus 100 before you needed to treat somebody. So if somebody was 75 years old, as long as they were, under 175, we said that's just because you got old and you have stiff arteries. We had really very bad drugs for everything, particularly for diabetes. It was really just insulin, sulfonylureas. And if somebody's glucose was under 300, if they weren't, as long as they weren't getting polyuria, polydipsia, or polyphagia, we really weren't that upset with their control. So obviously we have come a long ways in 2022, and there's a theme now in terms of prevention that's been there for quite a long time, the intensity of the therapy. And this is both lifestyle and pharmacotherapy. For LDL and blood pressure depends upon the risk status of the individual. So there's always been the attempt to try to personalize our approach, particularly when it comes to pharmacotherapy. So how do we do this? And that is where we've evolved quite a bit. We use quantitative assessment of risk for ASCVD using the Poole-Court equation for primary prevention. There's different equations in different places. We try to personalize therapy now. We have risk enhancers. There's the role of cardiac CT calcium scores is now in our guidelines. So let me give a case. A 71-year-old white woman, she comes in for routine annual physical exam. She has a history of arthritis, borderline hypertension, but she doesn't have a history of diabetes, cardiovascular disease, cancer, or chronic inflammatory condition. And she's a non-smoker. She's a family history of high blood pressure, diabetes. Her mother died at age 80 of congestive heart failure. Although she says her blood pressure is 140/80, she says it just goes up when she goes to the doctor. She's 5'5". She weighs 168 pounds. Her BMI is elevated, although for Houston it's less than normal. And then she is taking some NSAIDs for her osteoarthritis. Her lipid profile comes back, HDL of 70, triglycerides are a little high, LDL is 116, non-HDL is 142, HSCRP is 7, glucose is 115. So, a lot of us grew up with a Framingham risk score, and that was in the earlier sets of the guidelines. And her Framingham risk score would have been, if you go by ATP 1 or 2, some of the earlier sets, was 5% for a 10-year risk for MI. Now, the Reynolds risk score was something popularized by Paul Ridker. It included HSCRP. She'd have a 9% 10-year risk for MI and stroke. And the Poole-Court equation comes up with a 13.7% 10-year risk. So very different numbers here. Lots of questions and controversies about which equation to use. And the other one, though, I think it's even more important is what health conditions should we include for risk prediction to implement preventive strategies? So I think this is something that we really have not thought through in terms of the physician-patient discussion. So fatal and non-fatal MI, as I mentioned, that was in the past. Now we've included stroke, which is very important as we get into older patients, and particularly women, where stroke is more common than MI. But we don't include revascularization or angina. We don't include heart failure, and we don't include developing diabetes. So in middle-aged individuals, if you look over a 10-year period, diabetes is a very important issue. And what about heart failure? So think about this. Our concept is you sit with a patient, you give them the information so they can make decisions about what they need to do with lifestyles and medications. And we don't even include a lot of the things that they're most at risk for. How can that possibly be motivating? And I with all of you practice prevention, the biggest problem we have is basically has to do with adherence to lifestyle and medications. If you give someone a number that underrepresents both their short-term and their long-term risk, how can that be motivating? So, these guidelines, this doesn't make sense, I don't think. And it's something that's very frustrating, and it doesn't really make sense if you try to motivate individuals and talk about risk benefits by not telling them what all their risks are. Okay, so what are the steps that we start off with? We have risk assessment, and we've made a lot of progress, and we're making more progress. The next thing is, what do we do to reduce the risk? So this ends up being the discussions: diet, exercise, lifestyle changes, smoking cessation, pharmacotherapies. And then how does that process work in terms of prevention? Because it's a little different if somebody's coming in with acute MI and they go straight to the cath lab versus a long-term process in which there has to be adherence to get anywhere. So there has to be this joint decision-making between the healthcare providers and the patients, so the practitioners. All right, so we've been for many years, going back to Framingham, we have the classical risk factors: age, tobacco, blood pressure. We use in the equations sex, diabetes. We measure lipids. We have blood tests with quantitative assessment. So we use as a continuous variable LDL and HDL for risk assessment. You can use non-HDL and ApoB. We have hemoglobin A1C, which is usually not used as a continuous variable. It probably should be. We have measures of inflammation, which is a risk enhancer with HSCRP. And we'll talk a bit about some very good biomarkers for subclinical cardiac injury. We have imaging, calcium. You can use cardiac ultrasounds to assess the presence of disease. There are genetic variants, rare and common, and genetic risk scores. All right, so once again, going back to risk assessment, it's very important. What is the age of the person sitting in front of you in clinic? If they're less than 50 years old, then an ASCVD event is more common than heart failure. And you might be looking at a 10 or a 20 or a lifetime risk. And if you were to measure, for example, biomarkers of subclinical cardiac injury, they are usually normal. If you get up to age 75 and look over than that, it's a very different situation. Heart failure is the most common reason for a hospitalization. The time frame you're looking at may be shorter, particularly as older the person is. And then we see, basically, if you look at the predictive value of traditional risk factors, it becomes weaker. And then the frequency of elevated biomarkers of subclinical cardiac injury are much higher in that population. So we looked at this in the ERIC study. And I wanted to give a shout out. I saw Merle was online. Merle was our project leader at the NIH, NHLBI for quite a while in the ERIC study. So this was at visit 5 in the ERIC study. The study started back in the late 80s, 16,000 middle-aged Americans in 4 different sites, included African Americans, European ancestry. This was going at the 5th visit. And so at this point, people are a lot older than they were when it studied. They were 75 average age. They were 55 average age when the study started. And these were the demographics. Most everybody ends up being treated with antihypertensive medications. And now on statins is about half of the population. So that's a very big difference in medical treatment. And look at the levels of NT-proB, proBNP, and troponin T. This a high level. That's a mean level of NT-proBNP. So it's actually a median, and those are the IQR. So you can see a high percentage of people have what we would call to be an elevated level. What was the most common event in the next 3.5 years? Heart failure. Heart failure was actually as common as basically adding up CHD events. That includes revasc too. It's not just MI, and stroke. And obviously what ends up happening when you're an older population, the issue of total mortality becomes much more important as an event. So if you look in this age group, the powerful predictors were things like troponin T, NT-proBNP, and much more powerful predictors for future events than HSCRP, and also more powerful than lipids. And not surprisingly, what ends up happening is if we look at the PCE in this population, it's about 0.647. Now, if you go back to Eric in visit 1 and visit 2, it's around 0.8. So it works quite well. The biomarkers add a lot here. These are just NT-proBNP and troponin T. And in fact, if you just use biomarkers with demographic variables, the same way we do with EGFR. Who calculates EGFR? It comes up with a lab report. You could just have a lab report and add these 2 biomarkers, and it would do really a much better job than the Poole-Court equation for predicting events, be almost as good as if you had all the clinical variables. So there's ways this could be done in an automated fashion to help individuals sitting in clinic better stratify risk. Now, troponin I, we think of them as interchangeable for diagnosis of acute MI. They actually provide some distinct information when we're looking at prognosis for future events. And this was showing the differences, and we didn't have actually a terribly high correlation between those variables. And so this is something that ends up happening is that if you take a look, what we do in the field of preventive cardiology, there's a lot of excitement in the lipid field for example, ApoB beyond non-HDL cholesterol. Well, ApoB has a very high correlation to non-HDL cholesterol. Does it provide a little extra information? Yes, it does. But in terms of risk assessment, you have to measure HDL cholesterol. It may not be a risk factor, but it's a good risk marker. You need to have an LDL, a total cholesterol, because that incorporates the non-HDL cholesterol, and that's what's in the Poole-Court equation. Adding ApoB adds a very small amount, whereas if you were in the right patients to add NT-proBNP or troponin I or troponin T, you get a much bigger improvement in terms of risk prediction. Just some thoughts on that. I think that we don't always focus on what would be the best test to improve this. All right, so what's going on in terms of biomarkers? There's a lot going on basically in larger panels. Some of them are targeted panels. Then we have these very large panels for metabolomics and for proteomics. Genetics has been an explosion because of inexpensive testing. And then obviously imaging has really been, I think, one of the ones that has made the biggest impact where we are right now. Is coronary calcium scores are relatively inexpensive. You get a lot of information there. CIMT ultrasound, unfortunately, there's data to suggest that if we did this in a more systematic manner, for example, the way Fuster did it in some of his studies using 3D ultrasound, where you quantitate plaque and look at the carotids and the femorals, that's a pretty good test. A lot of the meta-analyses threw out the plaque data. And it's partly because it's not quantitative the way that we do it. It's a technically demanding procedure, but I do think that has a role in younger individuals when calcium scores are usually 0. And that we have never used this with the appropriate technologies to take full advantage of it. So this was a paper that came out in ATVP, done by colleague Bing Yu, looking at metabolomic data in the ERIC study. And what you see is that basically, if you look at certain patterns of the metabolome, that they will be associated with increased risk for events. And this is usually broken down into, this is a typical one, amino acids, carbohydrates. It's been expanded now to include steroid hormones. It's from a commercially available outfit called Metabolome. And you can, most of these have pretty modest hazard ratios. This was as continuous variables, but if you look at quartiles, they're still usually quite modest. So I think this is going to be more useful to understand pathophysiology, and perhaps looking at specific pathways, maybe helping societies what types of interventions, perhaps dietary or pharmacological, might be most useful in certain subsets of individuals. Proteomics. So we've had I've been the director of the core laboratory for the ERIC study for a long time now. And so we were one of the first ones to be trying to use, these were different. You can do multiplex with the plates or beads. We were using a flow model, we'll call Luminex, and you can measure multiple proteins at the same time in small sample volume. However, it's a little bit harder to get to really large numbers. You may do 4, 5, 8, 10, but our initial thoughts that we're going to be able to go out and measure 50 or 100 didn't work out that well. So there's 2 other methodologies that have really gotten taking off now. And one of them is the proximity extension assay. And so this one uses labeled antibodies, and then you with PCR, you're able to detect, quantitate the number of antibody pairs that have bound to a protein. And the aptamer assays uses beta mobilized aptamers. And so this is a different methodology. It's aptamer binding to proteins. And once again, though, this is actually going to be done, we're sequencing on the NovaSeq 6000 platform. So it uses some very exciting technology that's, as you know, all the sequencing has gotten way, way better. And then the gold standard would be mass spectrometry. So in the ERIC study, we have been working with a company called SomaLogic's 5,000 proteins. We've got that on 3 visits now. We did some work with Olink also in a case control study, which is finally getting published. This is some data looking at from the SomaLogic data. It's 9 different clinical studies, 22,000 participants. Out of the 5,000 proteins, they used 27, and you still ended up with a C statistic that was improved, 0.62 to 0.71. It's not a fantastic C statistic. This involved the ERIC study. It was used for initial validation. Started up with Hunt. This is for people with a known CVD. So ERIC and Hunt for that. And then there was a second part of the cohort was used for validation. And this went to multiple other cohorts. So there was improvement in the ROC, as I mentioned. Now, there was one caveat, is the protein that had the strongest association with the CVD events was NT-proBNP, which obviously you can get as a single test, and it gave quite a bit of the data that was observed with the 27 proteins. So I do think that we could do some smaller panels, and 2 that are available right now are NT-proBNP with either high sensitivity troponin T or troponin I, and they do a pretty good job improving risk assessment in populations that are middle-aged or older. What about genetics? Well, there are calls for screening the population for familial hypercholesterolemia. In the UK, they said this would be cost effective. And if you were to do that in people with premature MI, you would identify FH in about 1.7% of the patients. And they have an increased risk compared to other individuals of about fourfold. Now, another approach would be basically, this was the work that was done by the Broad primarily, and they looked at a couple of studies. The Virgo was people hospitalized with first MI less than 55. Then they looked at MESA for validation, and that looking at a polygenic risk score. And so looking at really a large number of single nucleotide polymorphisms, and they found that people who were in the upper decile of risk also had an increased risk of about 3.7-fold, which was about the same as seen with FH. But notice they found a lot more individuals. So a strategy that looked at a polygenic risk score plus monogenic traits might be more successful. Now, the question that comes up is, well, when do we start to implement this? And when should academic centers start to be looking at these types of things? And the argument can be made, well, with calcium scores and traditional risk factors, are we going to really move the needle much? So you have to put that in context of what's already going on with our patients. So the FDA approved direct-to-consumer genetic health risk scores in 2017. You add these 23andMe companies got started up much earlier than this, and we're doing a lot of direct-to-consumer DNA testing. Here's what's happened with DNA testing. This stops. I'm sure it's going up just as fast, if not steeper. But you're talking about 12 million people had done this by 2018. So it's probably going to be closer to 25 or 30 million now. So almost 10% of the population has been getting these types of tests done. So, I think the issue is, kind of this is a guy, back in a few years ago, is why do we need a wheel? What's the point of it? It's not, that doesn't do anything that's useful. Look, the technology is here, it's happening. And I think we need to understand in better ways, how are we going to use this in the field of prevention? And the other critical issue is in the field of prevention, in cardiology, let's put it for cardiology. The major focus on cardiology is on after the event has happened. So, it is wonderful that if someone is having an acute MI, we can get them into the cath lab and open up the artery and save myocardium. Now, the other one that comes up is people with, you're too late for that. They have bad heart failure. They have heart failure for other reasons. And then we can do a ventricular assist device and do heart transplants. There's a tremendous amount of focus, and most of the expenditures are on late disease. So it's like being a fireman. If you're a fireman and you go in and, you save people in a building, you're a hero. But what saves more lives? Firemen doing that, or people who are basically designing buildings that are safe, that put in smoke alarms and sprinkler systems. That saves far more lives than the dramatic heroic things. So I think the biggest problem we have in prevention is we do too little and we do it too late. And there's many reasons for this, but the advantage of genetics is that you can find out very early in life about potential risk. Okay, so you can identify FH. If we're going to do FH, we might as well screen for LPA, and that's it's moving along, but you'd have to do SNPs, and you can also basically sequence for looking at the Pringle 4 repeats, polygenic risk scores, not just for heart disease, diabetes and obesity. And then you could treat the families, lifestyle interventions in childhood, target the families. And when we need pharmacotherapy, you've got very inexpensive generic for the two major drivers are basically LDL and blood pressure. So one thing that we've also thought about is looking at how can we implement this into an academic medical center. So we did the Heart Care Project. This was with our Genome Center, and basically in cardiology, this was individuals who were interested could get sequencing of 158 genes where they were actionable. They got a polygenic risk score back. They got variants in LPA tested, and they got pharmacogenomics. This is the list of the categories of the 158 genes. So arrhythmias, cardiomyopathies, aortopathies, dyslipidemias, other CV-related diseases. These were only reporting were actionable findings. So this is likely pathogenic or pathogenic. We did not report variants of unknown significance. And the report, this is what it looks like. It went directly into EPIC. So this was not a biobank study. This was a study, an implementation of the study to say, can we do this in clinical practice? The reports went into EPIC. The physician got the report, the patients got the report. And this was an example of an actionable CVD gene. So this is someone had a heterozygous pathogenic variant of TGF beta 2. So that's Loeys-Dietz syndrome, and we had a patient like that in the study. There's polygenic risk scores came back. We only reported the top 5%. LPA risk variant was reported. Unfortunately, this LPA risk variant only works in European ancestry, and then pharmacogenomic findings were reported, but just for it was really only for SLC 1B1, which really mostly is important for simvastatin and for warfarin. So this came back into EPIC directly under labs. And what did we find? Well, 31% of individuals, 32% had something. So about 9% had a pathogenic variant, 20% had LPA SNP that put them at higher risk. The polygenic risk score of the top 5% was present at about 9.3%. Now, the PGX is stated, even though we had 49% had something, the percentage of people who were actually on simvastatin or warfarin was actually low. So it did not impact as much as you might think by that. This is a list of the genes. A lot of them were in lipids because we were involved with this for that, but a lot of cardiomyopathies also show up. Now we do have a heart failure transplant group. So what was the perception from the clinicians? Well, they basically felt that they strongly agreed that it improved overall clinical care, 60%. And they felt that it changed when you had a positive report, which was that it helped, change the care for that patient. We just also had a publication in what the patient perception was, and they also were pleased with this. So what we showed basically proof of concept that this can be implemented. It took a lot of education with our cardiologists and kind of coming up with some cheat sheets. Is what would you tell the patient about a polygenic risk score? What do you do if you have an LPA SNP? Well, you measure LPA. But then they were like, well, what do I do if it's high? Because most people weren't measuring LPA. And then when they came back with something and there was a pathogenic variant, then we would also try to make sure that the physicians understood what to do with that. And we got involved with some of our heart failure and EP people who were interested in genetics, helped implement this project. So what's going on? Well, we've expanded to doing this in South Texas. That's a Hispanic, mostly Hispanic with it, mostly from Mexico. Hispanic is, you could be in the Caribbean, you could be in Spain. That's a very different genetic backgrounds. This is whole genome sequencing now. Polygenic risk score is still getting worked out, but it'll be including a polygenic risk score for diabetes. And then we're doing another study looking at the long reads to get the apoic Kringle repeats, and it's clearly improving the situation. For particularly in Hispanics, the European variant is actually the most common variant, and it's associated with lower levels of LPA, not higher. So that report had a disclaimer about utility in Hispanics. All right, so how do we change too little and too late? Well, I think genetic testing for monogenic variants, which are actionable, along with polygenic risk scores, I think can give us an earlier step on things. We'd get FH, we can identify LPA. We need a protein measurement afterwards for it. Polygenic risk scores, the price is going down lower and lower, and you could start a family approach in terms of, particularly for some of these things, healthy eating, exercise, no smoking cessation. I've always, in my lipid clinic, I will see the parents, and if I FH, and now with high LPAs, bring in the children with this. A lot of the children are adults, but they get caught at an earlier time, and we talk about what they could do to reduce their risk long term. What do you usually use in these earlier life? Inexpensive statins and generic blood pressure medications. And later on, you can follow up with other biomarkers and imaging things. So start off with lifestyle. As people get older, you could end up with additional testing, generic medications. CAC testing is in general more predictive. It's a better yield if a man's over 40, woman's over 50. Not in everybody, but I think it's that. And so I think you can stratify individuals in regards to what is their overall risk and come up with a more targeted approach. So we've come a long ways in the area of prevention. I mean, saw Peter was on the phone there, but Peter was involved with the first studies. They were looking at a drug called Mavinalin. You got to have been around a long time to remember that was lovastatin. But we've seen statins come out, and then also the other things that have come out were ezetimibe, where we were involved with the development of that. Omega-3 fatty acids. A lot of the work was done at Baylor for the EPA, DHA for high triglycerides, and later on EPA. We're very involved with that entire program. PCSK9 inhibitors, all of these are new since I got started when I went to medical school. Inflammation, we had the trial with canakinumab. I actually spent most of my early career studying cell adhesion molecules and doing knockout mice and doing very basic research. And we've done a lot of biomarker research in this area. The area of obesity and diabetes has been dramatic with the impact of these SGLT2 inhibitors, GLP-1, and antiplatelet therapies. We didn't have good ways for dealing with thrombosis. So and also, improved anticoagulant. So it's been very exciting in terms of our ability to have new agents. Now we get more challenges as which individuals get which therapies. But it's really been, a great journey to be involved in my career at both kind of the basic science level and translational, and then also the level of clinical trials, and to watch this field evolve. It's still evolving. And what is really exciting is the impact genetics made, not only for PCSK9 as a targeted therapy, but now for LPA. And as you know, once you end up identifying by genetics that a loss of function variant is protective, or genetic variants that have lower levels are protective, then the races are off with either monoclonals, ASOs such as pelacarsen, and that the LPA Horizon outcome trial is fully enrolled, or olpasiran. This is the siRNA, and this study is starting up. We're beginning to enroll patients in that, and it's going to be a very exciting trial. And then there's another one in the pipeline. I think there's two others in the pipeline. There's another one that's not listed here. Now, high triglycerides also, because of genetics, identification of ApoC3 and ANGPTL3. We've already got an approved agent, ANGPTL3, for homozygous FH, evinacumab. It's also been shown to be effective in people with very high triglycerides. The ANG3 siRNA is in the pipeline. That data was presented at the AHA, that it did not have the impact as compared to the ASO. There was no problem in regards to the transaminases or fatty liver. There's an F21 analog that looks interesting. It lowers triglycerides about 50%, has beneficial effects on fatty liver. And the ApoC3 ASO, the FCS study has, this is a very, we know that Ballantyne worked. So olezarsen is a GalNAc, much safer, much lower doses, a big program ongoing. And there's also an siRNA that this is ongoing. Now, in regards to genetics and precision medicine, I know, we have been mostly focusing on FH. I think that looking at very high triglycerides is an area that is going to pan out for genetics. And I know Rob Higley and I don't agree on this. We've been working with a company called GB Insight, and they're reporting a wider set of genes. For example, it turns out that some of these very severe high triglycerides, we know biallelic FCS is quite rare. So what's more commonly defined is someone who has a pathogenic variant or a high polygenic risk score. And so this is the individuals who had both. This was a study that we did with Mike Davidson and Pat Moriarty, who were all using the same testing, people who had very high triglycerides. We published this recently. So we ended up finding out that if you had both a pathogenic variant and a high PRS, you had the highest triglyceride, you had also a greater risk for pancreatitis. It includes a larger set of genes besides the canonical ones that are seen with FCS. And I think one thing that if you take a look at your really tough to treat patients, if you're not doing genetic testing, you can miss some of these partial lipodystrophies. I know I missed one. I knew she had something. I didn't know what it was, but she had a PPAR gamma mutation. I have another one that's got a PPAR gamma mutation. When this first happened, there was supposedly 29 in the world. And talking to GB Insight, they don't have huge set of testing, but they've already got between LNMA, these are partial lipodystrophies, and PPAR gamma, they've got over 20 with it. So it's something that the JCL just had a paper that also looked at very high triglycerides with volanesorsen. I think it's in this month, but it turns out that the partial lipodystrophies responded perfectly well to ApoC3. This was the first generation antisense. So they will be responding well to this newer one also. I don't think we're catching it. I think it's something that we're seeing, but since we haven't had the genetic testing easily available, the diagnosis were not being made. All right, so where are we right now? We're in a very, we've come a long ways, but we're still, I think, it's kind of accelerating. It's a very exciting in terms of where we stand. And triglycerides, pemafibrate didn't work, but we've got the ASO, the ApoC3, ANGPTL3, this FGF21 analog look exciting. They're launching a phase 3 program also. Lowering LDL, we've got inclisiran, and we've got an oral PCSK9 that's looking quite promising. We've got the LPA therapies. In regards to anti-inflammatory, there's the trial with the ziltivekimab, which is CKD and elevated CRPs, and that's been enrolling with it. So there's a lot that's moving along in this field. So it's very exciting. And, we got some, no, it wasn't in here today. Let's see. Well, we got some good news today about the CLEAR outcome study reading out of the hit its primary outcome. Well, looking forward to seeing that at the ACC meeting. All right. So, research is a journey. It's not a destination. You never get to the end of it. You test a hypothesis, you find a lot of them are wrong, you find some things that work, but it's continually evolving over time. And so one of the great things, here's the Asperion announcement here. So there was good news to see this morning. We were involved a lot with that trial, and not the outcomes trial, but with the phase 3 lipid program. So it's always exciting to see something that's panning out and hopefully will help more patients. Let's see, we already have that done. So this was the issue. When you're on a journey, one of the things that's really great is all the people you get to go with for this. So I trained at UT Southwestern, happened to have an attending Joel Goldstein before he got the Nobel Prize, and I did a GCRC elective, and I didn't know who to do it with, and they said, well, there's this guy named Scott Grundy, and I'm like, who is he? I had never heard of Scott. but incredibly brilliant individual. Has done so much for the field at Baylor. Ended up working with Tony Gatto, Peter Jones, who's on here, has been a colleague for many, many years. And then we have all the postdocs and fellows who've been outstanding to work with. And then most of all, I have to thank my family for all the support that they have given, particularly when I was early in my career and working crazy hours. But the other thing about this slide is the importance of research. Now, it's shown in the middle picture is that there's two daughters next to me, but the one who's lower down with the sunglasses, that's my first daughter, Layla. And Layla and my wife would have died at birth. She had an APGAR of 0. It was a voluminous insertion of the umbilical cord, massive hemorrhage. And if not for an emergency C-section, resuscitation and a transfusion, she would have died, and my wife would have bled out. Now, I would have died in around 2002. I was diagnosed with stage 3B lymphoma and got a monoclonal antibody. When I was in medical school, everything was going to be monoclonals. But it turns out it was harder than we thought, because the murine ones caused a problem, immune reaction, and then you had chimeric, and then you had humanized. And humanized didn't work too well with bococizumab, did it? But then you had fully human with it. So it's an area where people stuck with it, and I was fortunate enough to get one of these things. But basically, research is the engine that has been driven the improvements in medical care. We have some fantastic generic medications now. And the other aspect that's so important is education. I know the people on this call tonight, most of you are educators in terms of, even if it's in your clinic, educating patients all the time, educating the staff with it. And one of the other things is the NLA has really been a great collegial group to work with. It's just been a real pleasure being involved with the NLA over the years. So I'm going to stop there now and open it up for any questions or comments, Guy. Let me stop sharing here.
Well, thank you, Christie, for that passionate presentation on precision medicine. Does anyone have any questions for Christie or thoughts? So general question for you, Christie. If we have, our colleagues who are in private practice, if you will, not attached to the academic medical center. So, what would you recommend for them to do besides the routine biomarkers plus or minus a calcium score in terms of their risk assessment?
So, for right now, I think that the CAC score, when choosing that, who gets a CAC score, I find it very helpful in terms of pushing people up or down for it. I think I would start looking at ordering more NT-proBNPs in your older individuals. That's going to be reimbursed. You'll have to mention that they have some shortness of breath with it to make sure that, but everybody gets short of breath sometime, right? I mean, if you're in your 70s for it, troponin T and I are more challenging in terms of getting that reimbursed. I strongly believe everyone should have an LPA measurement. I like the European that all adults should get an LPA measured. If someone's younger, children, anyone who's had a stroke or TIA should get an LPA measured for that. And then I think it's reasonable, if you're doing lipidology, that it's for a lot of individuals, and in terms of some kind of looking, is there a discordance between LDL, non-HDL, and either with, I personally felt that the NMR profiles as first developed by Otvos actually gave you more discordant information than ApoB. So I know Alan and I Snyder and I disagree about this, but ApoB is not the new technology. The new technology is NMR. ApoB has been around forever. It's more state, but the issue is, unfortunately, what happened with NMR is that after all this work to do all kinds of studies, is that other companies just came out and they had different magnets. They use a proprietary software, and the results are not the same. So, you know, when HDL Laboratories came out, they just, rather than using what was developed by Otfos, they just did their own thing, their own magnets. Then you have Nightingale, which is a different one altogether. Ron Krause's methodology is a different methodology for particle concentration that's used by Quest. So you don't know what you're comparing. It's like apples and oranges. So unless you're getting the same, like, you know, same methodology in the same patient, that's where ApoB is standardized. So it's the field is, unfortunately, with NMR gone backwards a little bit. I don't think we're ready for these big proteomic panels that you get a relative concentration. And it just, you know, I don't think we're not ready for that yet. I think genetic testing, I think we're ready there now for FH. But I think that, you know, you can look into some of these things, but I think for very high triglycerides that, you know, we should be considering it. I do, obviously, we're much more specialized in this area for having a lipid clinic. And if you're in general prevention practice, you may not be getting as much for it.
Okay, great. Thank you. There are two questions. I don't know if you could see the chat box, Christie.
Yeah. So, you know, so this is one for Merle. I think, you know, I think that the, Merle, you know, the recent ACC pathway is something that I was a co-author on that, but, you know, I think that it came up with a very high risk group is that really, you know, puts the threshold at 55. And so that what's a threshold versus a target? They're pretty similar. I mean, what ends up is the bottom line is you need to measure LDL and non-HDL. You need to get a lipid profile on people after you treat them. It's ridiculous that our quality guidelines are just this. Was someone prescribed a statin, and did they take it? Was it, I think, 85% of the time or 80% of the time? Well, you know, when I see someone in clinic, I don't even get the adherence data. The only way I get an adherence data is I measure lipids. So because we don't get something from the pharmacy when I'm seeing someone in clinic. If you're in a closed health system where you own the pharmacy and everything else, maybe you guys are getting it, but I don't even get that. So just because they say they're taking a statin, I see people all the time and their numbers are out, you know, numbers are bad. Like, what's going on? Oh, I ran out of my medicine. You know, they don't tell you until people or lots of problems with adherence. So, you know, I think this whole issue of not measuring, it's got to end. I mean, it has to become a quality metric again. It's not fire and forget. It just doesn't, you know, people need the motivation. One of the few things that improves his adherence is seeing the lab results for taking it. And then also when they're not doing well, it's lifestyle and diet. I'm in favor of, you know, lower is better. That's the optimal LDL we saw from the outcome studies is going to be probably 40 or, you know, 30s or 40s in terms of the very high risk people for that. So, you know, this question comes up for younger individuals. I look at the family history of these individuals and also the lipid profile. I mean, you know, with FH, it's clear you want to start early and you want to start, you know, in the early teen years, and you can start at age 10 to 12, but you don't want to wait till someone's a senior in high school going to college. Because at that point, basically, you're going to have, you know, one of the saddest cases I ever had was treated the mother and the uncle, and then the son. We waited till it was earlier days. I think we waited till they were like a senior in high school, went to college, and like, I don't need to take this. You know, I'm going to do it naturally. And, you know, he was eating well and exercising, and he was in a competitive ballroom dance and died about age 27 or something. You know, I mean, and both his mom and his uncle are in their 60s or 70s doing fine because they were taking their medications. So start early. Now, if they don't have FH, this is where the very high LPA, I think, is something that you got to consider. If they got a very bad family history and sky high LPA, I can think of a family I saw where you get 3 kids, all of them have very high LPA, but 2 have good lifestyles. One of them has poor lifestyle and bad LDL, and non-HDL and triglycerides are up. So, he went on a statin. He wasn't a teenager; he was in his early 20s. But, I think we want to be more aggressive with those people. Same thing if they have diabetes. Question about PRS for CHD. So I think if you were to look at preemptive approach, is that yes, I do think that, in particular, when you have if the proband is a parent, and then discussing with them, then this is the issue where we're not there yet, but if you could, even just that they have a PRS or they have a monogenic disorder. And I've had parents where they end up quitting smoking so they don't smoke around the children. They change the diet of the whole family. The issue is, can you try to get more of a family approach with this? In terms of LPA and aspirin, we have the data about LPA in older people in a post hoc analysis, but they were in there. I think the mean age on that was like late 70s, the Esprit trial. So those individuals who had either the SNPs or they had by a PRS for high LPA, the benefit outweighed the risk. Overall, for the study, it was neutral with it. So in terms of NT-proBNP, what ends up happening is, if you think about, heart failure. So I think where the first thing comes up for NT-proBNP is blood pressure. How many of your patients are you actually having consistently, under 130 or under 120? And if you see a high NT-proBNP, the first thing we need to do is aggressively lower blood pressure. I mean, ideally they're going to be under 120 for this. So we're not doing that. It's no one. If you look in primary care, I mean, people that you're seeing it is very rare to see someone who has well-controlled blood pressure in a high risk category. Do you follow me? Now, the other one that comes up is, I think the other one is that you can do more aggressively for all ASCVD. But the other thing to consider is, if you had a patient who has if they got an elevated NT-proBNP, they've got diabetes, but they don't have ASCVD that's clinical, then they ought to be on an SGLT2 inhibitor, right? I mean, that's the big benefit of those drugs, are to prevent heart failure. It's a little bit beyond the guidelines, but I think it's logical that we could look at what are the things that you could do for that individual. Certainly, if they have diabetes, you have an indication there for it. The other one might end up being is for some of those. I just think you can use this in terms of it mostly as a risk enhancing factor, but there are certain therapies that we know are better for heart failure prevention, and some are for ASCVD prevention.
All right. I think, Christie, you answered everyone's questions and opened up a lot of new windows of questioning and treating our patients and various preventive measures. So I want to thank you for taking the time and addressing us this evening. I want to thank everyone for taking time out of their evening to participate in our Neela Nights. And, with that, Dr. Ballantyne, thank you so much.